COVID-19 webinar series. Today's topic is the Nurse Wellness Survey results, and this is RNAO's pulse on RNs, NPs, and nursing students. So welcome and thank you very much for joining us. This is going to be an interesting discussion today. So we just wanted to remind you that RNAO is here for you now, and we have been since the pandemic started almost 1 year ago, which is the anniversary coming up on Thursday. So we've been listening and learning to you. We've been learning with you. We've been speaking out. We've been advocating for you, connecting and supporting for you, cheering for you, keeping you very well informed. We've had the Together We Can Do It campaign, and we are actually having a candlelight vigil on Thursday to mark at 7 p.m. And we encourage you all to join in on that candlelight vigil to mark this very somber 1 year anniversary of the day that the pandemic was declared 1 year ago today. Also, so today is a launching of some of these preliminary results, and then we invite you to join us for a follow-up discussion next Wednesday as part of our COVID webinar series, the How Are You Feeling During COVID-19, our wellness check in there. Sorry, I've got some dings on my phone here. So today, the agenda, Doris is going to provide us with some introductory comments and a welcome. And also I think she's going to, together with Matt Kellway, our Director of Nursing and Health Policy, to walk us through some of the work and well-being survey results. Morgan Hoffarth, our RNAO president, is going to join during today as well. So when we walk through the work and well-being survey results, we're going to be talking about who the respondents were, some of the impacts of the pandemic, pandemic responses, and the future at work. We'll have time for questions and discussion, and we ask you to use the chat box for your questions, and we'll end up with conclusions and next steps. So to participate today, we are recording this session, and we ask that you use the chat box to add your comments and ask any questions that you might have for our speakers today, Doris and Matt, and the rest of our policy team who might be online. So Doris, maybe I can pass it over to you to welcome and set the stage. I'll stop sharing my screen so that you can share yours.
Thank you so much. And I know that Olivia is taking care of the share screen, so that's great. Let me first start by thanking everybody for participating today. And I also want to share why did we launch the survey, and thank Kim Jarvie, who has taken a key lead in actually developing the survey with us and doing the analytics of it. Let me start by saying that these are preliminary results. I cannot stress enough to put this in context that these are preliminary results. And the reason that we wanted to share these preliminary results is we actually wanted to see if they resonate with you. If this is the same that you all are feeling, if this is what you have been experiencing. I will ask Anne-Marie or you, Susan, to put the slides on because I am not sure I see the slides. Let me tell you the reasons for launching the survey, meanwhile that the slides go in the screen. First of all, as Susan said, it is a year since the pandemic started. It is, and it has been, and will continue to be, a very unique situation for all healthcare providers and other essential care workers, and for nurses in particular. And I say for nurses in particular because at the end of the day, nurses are there 24/7 next to the people in this province, whether it is in the streets of Ontario, whether it is in shelters, whether it is in the nursing homes that suffer, as you know, a brutal tragedy or whether it is in ICUs where nurses for the last few months have been very heavily working, and in fact in any sector. And from time to time, we heard from nurses about these challenges, specifically to certain sectors at the beginning, and then increasingly across the entire profession, partially because the length of the pandemic is such that it builds on top of whatever else that happened before the pandemic. So that's number one. Second of all, our colleague, Stephanie, taking her own life, shook the nursing profession to its core. And many of us, including RNAO, ask ourselves, was it there something else that we could have done? Is it there something else that we need to do for nurses now? And this is, as you know, as we started joining the conversations heart to heart. So this survey for us was simply a way of taking the pulse. We will tell you at the end where we are going with the survey, and we will also tell you what's coming next in terms of the survey. So let me get to the details of the survey at this point. First of all, it was launched on January 29, and it closed about 2 weeks after. So a very short period that really was simply to check the pulse. Second of all, it was made available to both RNAO and non-RNAO members through mainly social media and through the In the Loop that members only get, and through the blog that goes to everybody. So it was highly publicized, very short time frame, and within that short time frame, over 2,000 nurses actually responded to the survey. So that is pretty significant. To be exact, 2,100 and change. It involved a mix of RNs, NPs, and nursing students, and that was the target population. Today's presentation, as I said, is simply to check the pulse. So as we present, I would very much ask that you actually put, as you hear us, your comments on the chat. Your comments about, does it resonate with you? If anything else, what would you add in terms of your experiences? What we want to know is to make sure that these 2,100 RNs and NPs and nursing students that responded, that it represents actually the experiences of at least most of you. And you will hear also, as I present some of the results, and then my colleague Matt Kellway, that while there are many commonalities, each nurse experience was their own. Each nurse situation is their own. Because like any of us, each nurse brings their own life and work package in their shoulders. You know, we all work with our own life package. So while there are commonalities, it's always important to remember that these are numbers that at the end of the day, the commonalities are good to create policy and programs, but the individual experience of each nurse can never be forgotten because we need to account for those. So with that, let me give you a bit on who are the respondents. First of all, about the status of these individuals. As you can see, 91% RNs, 4% NPs, and 5% nursing students. Not actually very different than if you look at the college. And when we do the final, we will actually parallel this with what are the percentages of RNs, NPs, and nursing students related to college data. So you can see how representative the sample is, and it was a self-selected sample. The second piece is were these people RNAO members or not? While about 35% of nurses, RNs, are members of RNAO, and about close to 60% of NPs are members of RNAO. Here, 82% were members of RNAO, and that's not surprising given that in a way they got more reminders because they got the in the loop, which non-members don't receive the in the loop, right? So that explains that difference. And about 18% were not members, which is not an insignificant number because you have 386 individuals that were not members of RNAO, so it gives us a good sense. Here is the domains, the age distribution, not the domains of practice, but the age distribution. You have there 21 to 25, 25 to 30. So again, we will parallel this to the College of Nurses, the age distribution, to see how this parallels to actually, we will see in the future a second bar that will show us what is the age distribution vis-a-vis the college, and we will see how representative it is. My impression overall and my colleagues is that this is pretty representative of the college age distribution. The next one is how many years have you been in nursing? Well, of course, this makes sense, right? If that's the age distribution, right? Aside of second career nurse, those that went to nursing as their first career, this parallels the age distribution pretty much so we shouldn't be too surprised about that. Current work setting. Again, if you look where the majority of nurses work, and if you look at the distribution by the college, if anything, this parallels. When you put teaching hospital with large hospital with small hospital and you cover all of that together, right? You get to about almost 50% of them in hospitals. If you look at the college data, it's probably higher than that, which is an encouraging thing, says the majority of nurses, and we had a lot also of nurses in community care and in long-term care responding, so that actually is pretty inspiring to us. Let's talk about the impact of the pandemic. And as we hear, answering to Maria, no Maria, RPNs were not surveyed. RNAO, we RPNs did a separate survey and we thought it's not appropriate that we delved into that. So this is really RNs and Ps and nursing students. I want you to think about the impact of the pandemic in context. Two types of contexts that I think are critical for you to think about. Number one, the context of how we went into the pandemic. I remember when on March 11, the day that the pandemic was deemed a pandemic by Dr. Tedros, I was sitting actually in a consultation with the team of Minister Fullerton about the situation overall in long-term care. And it's related to a consultation on the previous inquiry. And I remember I was saying the words, and Matt Kellway was with me. You will remember, Matt. I was saying the word, we are going into the pandemic because it's only a matter of days or hours until it will be called the pandemic. And we are going so poorly prepared. We are going with deficient staffing, with deficient models of practice in long-term care, and we will pay a price for it. We need to fast track hiring in nursing homes. And sure enough, ding, ding on the machine, I look at, and it was obviously WHO announcing this was a pandemic, and the rest is for the history books to say. So what I'm saying here is SARS, that was also difficult experience, colleagues, did little to prepare us for this pandemic except to the hospital sector. SARS served as a warning sign for the hospital sector. And yes, this time we prepared very well for the hospital sector, but we did that to the detriment of other sectors. The question will be, will we learn from this pandemic? So in future ones, because they don't happen every 100 years, that actually all the sectors are sufficiently prepared to withstand such a situation. Second context that I want you to think as we look at the impact of the pandemic, the length of this pandemic. SARS was very short-lived, if you remember. This pandemic is lengthy. It's lengthy on Ontarians, it's lengthy on Canadians, it's lengthy on the world, and yes, colleagues, it's lengthy on the nursing profession. When you think that your vacations have been canceled, this happened in long-term care, in other sectors, when you think that we have gone through wave after wave, when you think that people are asked to long hours, when you think that at the beginning we didn't even know enough what was going on and people will go home afraid, think about the context of the length of this pandemic, right? And that's a learning for the future in itself. When we know it's a situation that will be long, once again, all sectors need to be well prepared. So, has your work been impacted by the pandemic? Honestly, it looks like a foolish question, but one that we needed to ask. You know, you cannot conduct a survey and not ask the questions, because then you are assuming that you know the answer. Well, of course, 96% said that it has impacted, right, their work. How concerned are you about work-related risks to your personal health due to COVID-19? A very small minority, 5.7% or 117 respondents, says not at all concerns. If you take the other extreme of the question, extremely concerned, you have 29.7. 29.7 vis-a-vis 5.7. So obviously, then when you look at somewhat concern, moderate concern, extreme concern, you can see already the heaviness of this pandemic on the backs of our profession. To what extent has COVID pandemic affected your work? And let me go back for a second, because I think this is important, right? It's not just enough to look at these numbers. The question is, could we have done something to ameliorate this? And we will delve into this when we get into the report about this survey, because yes, we could. You may remember RNAO asked repeatedly to give PPE to nursing homes first. Remember, we at the end didn't have in the first wave a lot of problems in ICUs. We didn't even use all the PPE we had, right? But nursing homes didn't have it, not PSWs, not RNs, not NPs, etc. So yes, there were things we could have done where people would have been less afraid of the work-related risks to their personal health due to COVID-19. To what extent has the COVID-19 pandemic affected your work-life balance? Again, kind of a rhetorical question. I think I can ask even any of us that has not been in the front lines to answer this, and we will say not to a great extent, but I would say to a huge extent. It has taken our lives over, right? And we hear that in the weekly webinars about heart-to-heart conversations, the comment, we can't get away from it, right? How would you rate the level of stress you have experienced in your job due to the pandemic? Well, again, very low is minimal, 27 of our colleagues, and a very tiny percentage, 643, which is a large percentage, 31%, very high. So now picture this. You are putting length of the pandemic, a year, plus high levels of stress, right? You're layering both the intensity of the stress with the length of the pandemic. If you were putting that as a denominator, the length of the pandemic, and the stress as a nominator, well, it gives you the result, health problems. That's the outcome, right? So very high. And then if you couple together high levels of stress with very high levels of stress, well, almost 60%, guys. Recipe for disaster. Please rate how well you perceive yourself to be coping during this challenging time, with 10 representing excellent coping and adjustment. Okay, so you will see a small minority coping excellent, and you will see in the middle, which I need to tell you, I'm impressed by that. Half of our colleagues thought, not too bad, not too good, right? That's encouraging. I was afraid on this question, and my colleagues too, that it will be much, much tilted because of the length of the pandemic. But then when you start to cobble, right? 7, 8, 9, and 10, or at the very least 8, 9, and 10, like how long can a person, let alone a whole community of nurses, withstand the stress and the hardship and the fear and all that already we have seen, and more that you will see, right, for this length of time. And this is why we think that the coping became more and more difficult with the time, and some of the tragedy also came at that point. So we are not going to get into the details of this, of our own self-reported coping and adjustment by age group, but we will do that in the survey. I just don't want for us to spend the time now on that, because will take us away from the rest. Have you taken time off to manage stress, anxiety, or other mental health issues related to your work during the pandemic? Look at that, 74% have not. And I want to focus on that 74% because I think they are Herculeans. I think that they have been tremendous, our colleagues. And I tip my hat for everybody, because not to take time off with that level of stress and anxiety, it's remarkable. It's remarkable, right? 26% though needed to take the time off because it just was beyond what the CAP could handle. Have you sought mental health or well-being support during the course of the pandemic from any of the following? So this tells you where. So the great majority, basically, they supported themselves with their families, right? But then you can see that some supported themselves with the workplace programs, et cetera, and with colleagues. We will come back to the issue of families. It's a complex situation on the issue of families. We will see that in other questions. How would you rate the overall support you have had from? The blue is your employer. The orangey or burgundy is government, and green is RNAO. Of course, it's pleasing to us that RNAO is the highest. We need to tell you we're not surprised. We heard that through the pandemic, the number of emails and comments we get daily from both nurses and non-nurses, members and non-members, RNs and RPNs and NPs and students and everybody is huge. And also there is a predecessor to this. And I do want to acknowledge Linda Lee O'Brien Palace. Years ago, those of you that were at the board with Linda Lee at the time, Linda Lee on her own one day decided she was doing something about nurse satisfaction and happiness. And she came back to the board. This was an independent piece of research of her. She came back to the board to say, guess what, guys, in the Linda Lee mode, RNAO members are happier people. Well, I'm glad to know that they're happier people. If you put the good, very good, and the excellent together, the percentage is pretty high. We are always going to strive that it be higher. I need to tell you that I am also pleased at the feedback about the employer. I was afraid of this question because RNAO tends to hear either kudos about RNAO and what are the problems with the rest of the world. Well, for those of you that are employers, and I saw Karima is here and others, take pleasure. You know, yes, of course, always you can do better, but you were in situations that were unbearable, whether you worked in long-term care as a manager or as a chief nurse or as a director of care, or where you work in a hospital, or in home care, you were put in a situation that you were the sandwich. You were the sandwich. You were basically prepared for the hospital scenario, but not nearly enough for others, and then you were asked to swim with it. So take credit in terms of the fact that at the very least, the great majority was on the fair side, and that then you also had not an insignificant number that spoke about good, very good, and excellent. And yes, of course, we need to do better, but for that, we also need to give you the tools. I am sad that the government was rated this poorly. I think that this deserves a conversation, not that we don't have. I have them directly with the premier and with ministers, but a conversation that needs to continue. I think that we will see in the comments, but also it has been all over the media since the beginning of the pandemic. There were several things of why nurses in particular don't feel supported by government to this day. Number one, the struggles in long-term care and in home care and for securing PPE were horrendous, quite frankly. Partially because there was not enough PPE, partially because most of the PPE went to hospitals, etc. Second, when it became the time of clap, 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 PSWs took the first stage at the clap, clap, clap. And yes, PSWs deserve clap, 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 but so do nurses. And the word nurses, if you Google my premier or my minister, say the word nurses in public, compared to PSWs, it has a lot of ways to go to make it better. The premier started in our Queen's Park Day to amend that and to bring more light to the contribution of nurses, but in reality, whether it was not there with government. So that is something that needs to improve, and the time is now to improve it. The time is on March 11, and this is another day why we did this presentation today, because March 11 will be a time to remember the lives we lost. And yes, the great majority were PSWs. They were also a couple of nurses, right? So they gave the ultimate sacrifice, their lives. And also May 11 is about the hope to the future. And if we don't want to get, and we will share data about that, to a horrific attrition of nursing, a lot of more public recognition in the way of words and in the way of deeds, meaning in the ways of funding. The premier committed to 10,000 and change more RNs in the next 4 years. We want 2,500 of those this budget year. We want 2,500 of those before elections, so 5,000 before elections. And the premier also committed to 5,000 RPNs. I am sure my colleagues from RNAO want at least 2,500 of those before elections too. So both the discourse of thanking nurses and the deeds of putting the funding for them and the resources to make for good work is a must, and is a must now. Do you feel that discussing your work experience with family or friends is a burden? Remember, I told you that the majority, we found that the majority of nurses try to find support amongst their families. But look at this, right? A great majority said that sometimes they feel that actually they're putting burden on their families by discussing these issues. Are you discouraged by your employer from discussing your work experience? I need to tell you that this was music to my ears. Colleagues, there was a time when almost every nurse felt that they couldn't discuss the pandemic outside of the workplace. Music to our ears. The great majority, by and large, said never feel this way. And then another good chunk, sometimes I feel this way. Of course, we need to deal with the ones that say, yeah, you know, I always feel this way, or many times or often. but the great majority. This is great progress for our profession. On this, I want to thank people like the gritty nurses, the What's Beeping, the Birgits of the world, and many others, not only RNAO, because we have been a lot in the media, but no one can really touch us, but nurses that are in the workplace and are speaking out publicly and honestly and fairly about what it means to work during a pandemic. So to you in the front lines, kudos for doing that. And to you that are in management and executive positions, kudos for both, not only enabling, but facilitating that. Let me ask my colleague, Director of Health and Nursing Policy at RNAO, Matt Kellway, to take you on to the future at work, because it is sobering and it builds on all these points that we asked before, and then we will move to conclusions. Matt, back to you.
Thank you very much, Doris. Good afternoon, everybody. Pleasure to be with you today. Yeah, this part of the presentation, part 4 here, talking about the future of work, gets at some of the implications of the experiences that Doris has described as reported by the respondents in the survey so far. On the first slide of this part here, we ask people what their current work status is. Susan, are you able to?
I can move you. I can move you.
Can you, Doris? Okay, that's great.
Well,
Can you...
they took my share screen.
Oh.
So I cannot move you. We are moving back. If you give me the share screen, Anne-Marie, because I know the presentation in and out, that would be good. Anne-Marie?
Doris, you have it.
Thank you, darling. Okay, here you go.
There we go. So what we wanted to do with this first slide is set a bit of a baseline on respondents' current work status. So you'll see that about 70% of the respondents are working full-time. A big chunk are part-time and a number casual. Doris has mentioned before, and those of you who filled the survey out will know that you had the opportunity for some free text responses. And when you dive into the free text, you'll see that the respondents to the survey were working under every conceivable working arrangement, including self-employment. To the next slide, please, Doris. In terms of hours per week.
Here we go.
There we go.
Sorry, Matt.
That's quite all right, Doris. We, you'll see that in terms of hours per week, the respondents tended to work full weeks, most reporting a 31 to 40 hour work week. About 600 or just about a third of our respondents were reporting working a 41 to 50 hour week. But again, when you go into the free text responses, you find that the work burden of this pandemic fell very heavily on a minority of nurses, and some of the nurses were reporting work weeks well in excess of 50 hours.
And if I may, before I move the slide, Matt, to add, so now layer preconditions that we went to the pandemic, shortfalls of staffing, length of the pandemic, how long it has been, and then picture that with over 50 hours of work. Right?
Yeah.
It's like toxic.
And on up. Respondents were reporting 60 and 70 hour work weeks and unrelenting work weeks too, for weeks on end. On slide 36 here, how many hours would you like to work in an average week post-pandemic? So with this slide, we start talking about the future and gauging respondents' views on the future and their kind of working desires into the future. And it shows that closing in on 40% of respondents will be looking to forward to working less hours post-pandemic. You'll see that there's a very small minority who wanted to work more hours. And one of the interesting things about the pandemic that one finds in the responses is that it was the pandemic had a very heavy burden in terms of hours of work on many nurses, but there were also some nurses who had very little work to do through the pandemic because of the setting or domain that they were involved in. And so that probably accounts for that number seeking more hours.
Absolutely, it does, Matt. And it also links to previous work that we have done at RNAO that talks about overemployment with underemployment. This has been, I mean, we have our own careers. Sue showed at the beginning in our own careers. In the midst of this mess, when people are saying we don't find enough nurses, there are 2,500 RNs working, looking for work, guys. So you have the underemployment with the overemployment, and again, that's something we need to rebalance.
And on the next slide, asking folks if they were eligible to retire, and 22% said yes. So this creates an interesting baseline when we compare that to the numbers who are planning on retirement. So on the next slide, you'll see retirement plans. And approximately 15% of respondents report planning to retire within 2 years of the pandemic ending, and over 1/4 of the respondents within 4 years. What's interesting is when you go through the free text, you see a lot of people responded that they retired during the pandemic. So unfortunately, this slide doesn't account for a kind of rush to retirement that may have already started during the pandemic. But certainly what we're seeing here is a planned retirement rate that is well in excess of the normal retirement rate in the profession, which usually hovers in and around 2 to 3%. And here we're looking at about an 8% per year retirement rate over the next 2 years, and then slowing down a little bit to about 6% over the next, over the average over the next 4 years. And so that is, yes, Doris, go ahead.
Before we move into the next, I want to put an alarm bell on this slide. There are many times that this type of information is used for the wrong direction. Oh my gosh, we will have retirements, a shortage. We need fast solutions. And we get into the wrong models of replacement even more. RNs with RPNs, RPNs with PSWs, PSWs with whoever now. And what you will have is an even larger hemorrhage of RNs. RNs want respectful work. RNs work, if anything, an increase on the skill mix, and I would suggest to you RPNs too. So we need to be very, very thoughtful about this type of information. And the solution, of course, that we will bring to you is that right now there is a huge surge in applications for nursing schools for the RN side. So we will talk about that in the conclusions. But when people will see this slide and you will have people saying, oh, it's a crisis, they're retiring already, more will retire, we need to quick model to this model, that model, the other model, and start to bring other people, those organizations that will do that will get into more trouble, and the others will become magnet places that will attract their own workforce. Watch it, because this is important. And it has happened in past history of nursing.
So keeping that caution in mind, we'll look at this question here. How likely are you to leave nursing for a different occupation post-pandemic? And what we're seeing is that the retirement issue may in fact be compounded by the likelihood of significant numbers of nurses leaving the profession. Nearly 10% of respondents indicate they are very likely to leave nursing, and a further 7% of respondents that they were likely to do so. And we started to unpack this a bit. So on the next slide, you'll see the responses by age group, and I would point you to those yellow highlight rows there with the age cohorts 26 to 30 and 31 to 35. And you will see that this, what it shows is that those are more likely, they respond very likely more than any other age cohort on the chart here. So you'll see the number 13% and 13.3% for the 26 to 30 and 31 to 35 age cohorts respectively on this chart. Those numbers are in excess of typical departures for those age cohorts through history, according to CNO data. So we'll be unpacking this data a little further to better understand it as we go.
And one of the colleagues, Matt, said, and let's not forget the ones already left. Of course, we will not, because we will be comparing, when Matt says unpack, we will be comparing this data to the trending of data of the college. So absolutely, we will not forget. Yes, thank you for making that comment.
Yeah. Yeah, okay, and on the next slide, we see the probability of leaving nursing by after the pandemic by stress levels. And you'll see that those who are reporting very high stress levels through the pandemic have higher numbers or greater likelihood of leaving the profession. At least that's what they're indicating. So there you see 18.7% of people reporting a very high stress level through the pandemic, indicating that they're very likely to search for a different occupation post-pandemic. And if you flip again, thank you, Doris. And here it's probability of leaving nursing after pandemic by work setting and percentages. And so the potential human resource issue from the departure of nurses from the profession may not be evenly distributed across all sectors of the health system. And here we see that if you look at the darker rows, you'll see that public health, large hospitals, small hospitals, and community care are reporting more likelihood to leave the profession. And interestingly, you look at primary care and academia as two settings where people indicate a less likelihood to leave the profession.
Which again, Matt, it really connects hand in glove with the burden during COVID. Primary care, if anything, was underutilized. In fact, those nurses to this day are asking, involve us in the vaccination at least. So they are actually on the other spectrum that they want to be more used. The others are just choking.
Yeah.
So,
these numbers are good proxies for where the burden of the pandemic fell in terms of health system sectors, for sure. And yeah, so the next slide then, leaving nursing by RNAO membership, and you see that RNAO members are less likely to be leaving the profession than their non-RNAO.
So that was not a promo slide, but it could be used as a promo slide for the employers. Make sure your nurses join RNAO. And Linda Lee, I remember, said exactly the same. This is the second survey in my history at RNAO that has been done. Maybe we should do it more often, but there is a truth to it. And partially it's because they are well informed, they are well engaged, et cetera, all the aspects. But this is something that from an RNAO perspective will be nice to kind of do a deep dive and understand the whys and do some more work with it. Maybe it should become mandatory. Here you go.
The baton is back in your hands now, Doris, for the conclusion.
Absolutely. So number one, to remember what I said at the beginning on behalf of my colleagues and RNAO as a whole. There are universal experiences, absolutely. There are universal numbers, absolutely. But each experience is unique, right? Each person endure this pandemic, and that goes for all of us in different ways, okay? The pandemic is jeopardizing the tenure of nursing colleagues in the profession, and more so for younger nurses than for older. However, those that are close to retirement, remember, you likely, many of you, like me, heard about colleagues that told us, Well, I'm sticking around because I cannot leave my colleagues alone. But you know, when this is all done and over, it's time to retire. I was thinking about that anyways, and they will this time. You know, in years past, when people would say that, I kept saying to people, no, we will not have this level of retirement. No, we will not. I said to Anthony Dale during the holidays, even in December, watch it, Anthony, because people will start to retire. Ways to lessen that and to keep the younger nurses is, as one of the colleagues put on the chat, retention, 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 recognition, 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 funding to increase staffing so they feel that help is on its way. Departures from the profession will threaten the health system. For those that will choose to use crisis to do structural change that they had in mind anyways, like RN replacement, which has been a catastrophe, and this is just the proof of the pudding, watch it, because you may stay without health system. There is no health system that we know in OECD countries that doesn't have a rich dose of RN care. And so watch it, because you pay for what is it? You get what you pay for. Simple as that. And you all know the studies of Linda Aiken and others in terms of outcomes. You get what you pay for. And I mean that in terms of funding, and I mean that in terms of recognition. Continuing to replace RNs, and now also RPNs, and then PSWs, sends a clear message. We can do without you. Well, for once, we may need to do without everybody if we continue this way. The impacts of departure may not be evenly felt across the profession. And I would suggest to you, it will not be felt even across one sector. Those sectors that will push up and improve their conditions of their work for RNs, RPNs, and PSWs in long-term care, those and NPs, those places that will improve the conditions of work in an ICU with models of care where there is clear accountability and whether the RNs feel that they have the resources they have to do the work will shine, and the others will go more and more to the bottom of the equation, because nurses will have a lot of choices where to work. And one colleague said to me today, one colleague, a chief nurse, said to me today, you know, we train them and then off they go somewhere else. Well, that will continue to happen more and more and more, because they will go where the working conditions, where the leadership support, where the education, whether the opportunities, and where the staffing is such that they feel that they're doing a good job. None of us wants to feel 90% of the time that we are living without having done this, that, and that for a patient. You can have it, you know, one day a week, but when RNs and RPNs in other sectors or in other units feel that they cannot deliver the quality of care that brought them into the profession, off they go somewhere else, either to a different workplace or to a different profession altogether. Pandemic planning needs to be real. If I tell you, and if there is media, you are welcome to listen to this because it's true. If I tell you that today I participating in a meeting about actively ramping up the use of primary care for vaccination at this stage, a week before we will be flooded with vaccines, it tells you we haven't done pandemic planning. We need to have from PPE to everything else, including human resources, ready to go at any minute, because there are 4 pandemics that I can count even in my tenure at RNAO, right? So once in a while is a huge one, but you never know which one is a huge one. Nursing human resource planning is so long overdue that it's not something we need to talk here. Health system transformation, where we don't depend only on hospitals. If anything, this pandemic was a shift again to hospital centralized care. Hospitals were asked to take charge of nursing homes. Hospitals were asked to take charge of what should be community mental health. Hospitals were charged of taking IPAC. A system that is high performing cannot be a system that is centered around hospitals. You need all the sectors involved, engaged, and robust, from public health to primary care, to home care, to hospital care, to palliative care, to everything, including long-term care, and that's not what we have. The OHT model started to go there, but as soon as the pandemic came off, it shifted. CEOs of hospitals and civil servants and government politicians that really don't know enough about the system, it's not their job, but off they retrench to their safe place, hospitals. Let's give to the hospitals to do what they need to do. It didn't work. Nursing career supports are a must, and the sooner we move to that and provide opportunities, the sooner that people will stick in our profession, because we need. We will do a deeper dive into this data and production of a report. We will be doing a lot of cross-tabulations between stress, age, and work sector, et cetera, et cetera, et cetera. Also of the narratives, there are beautiful, beautiful quotes of what people are saying that gives you a bit of fabric, a little bit of, you know, of narrative and story and lived experience to these dry numbers. And we will continue, because we are now engaged in a mega survey with our colleagues from Australia and with Nursing Now that will involve 136 places, and RNAO is leading that in Canada. So stay tuned. It will build, and it's a survey with a research with proven tools. Is a research actually, and it will give us a lot of food. But colleagues, we actually know what needs to be done, right? We know. We always have known it in nursing. Staffing, supports for education, supports for retention, supports for the front lines and for the managers and for the chief nurses, and the ability to thrive, not to just survive, the ability to thrive. That's what keeps a profession going, not surviving. We will continue with the open forums and checking the pulse and providing support. And we will continue with the policy work that RNAO is driving, which is second to none. This will only help us build into that. So with that in mind, I would like to open it for questions first, and then we can do the last slides to talk about the event on Thursday, etc. So let's open it for slides, for questions, for comments. I guess the first thing I would like to hear, if it's okay, if people could just write on the chat, did it resonate? A simple yes or no. Or you know what, in a scale from 0 to 10, 0 being not at all, this is like another language, to 10 being 100% it resonated with me. Can people put in the chat, how did it resonate with you? Let's give you a minute. And I don't know, it would have been good to have done a poll. I don't know how long it takes PG or IFRA to do a poll, but I see the numbers already there. Yeah, it will take time to do a poll, but that would have been a good thing. Everybody would have seen it. But I can see the numbers are flying there on a 10. It does. Well, it resonates with, I know for chief nurses, it will resonate what you have heard from your own staff. For managers, you are the ones in the sandwich there. We tip our hat for you, colleagues. For frontliners, you know, we all have worked very, very long hours, but I need to tell you, when I'm exhausted, or my colleagues are exhausted, and we speak often in the staff meetings about this, we always say we are not in the front lines. So Doesn't matter the long hours we put. You are in the front lines. You are the ones that were afraid if you are going to bring the virus home. You are the ones that sometimes didn't have the right PPE or the PPE at all in long-term care. You are the ones that were asked to stay for an extra shift and needed to find last minute someone to take care of your kids. And if I speak about one colleague that I hope is there listening to this, you were the one that needed to go on self-isolation because you got COVID, and your daughter, 9 years old, needed to look after herself. I cannot say more than that, colleagues. Thank you. Thank you, thank you, thank you, thank you, thank you on behalf of RNAO for all the work you do in absolutely every area and every sector. Let's open for questions, please.
Hi, Doris. There are lots and lots of comments in the chat box. I think you've been identifying some, and Ermagine is also reviewing all this. But what I'd like to do first, if you don't mind, is just capture some of the comments and then lead to the questions. So there are lots of comments about the data, suggesting that the data is shared with organizations, that we do have to be really careful about what we use, how we use this data. So I think that was mainly referring to, Doris, when you were saying not to jump to immediately hiring people who maybe aren't RNs, and also to share the results with for human resource planning for the near future. So that's kind of about the data. Speaking out.
So let me comment on that. For the exact same reason that we are very concerned and mindful that we don't want this data to be misused for the wrong purposes. There are organizations, just so you know, I am aware, and I have spoken with some of those presidents, that basically the song is, we have a shortage, we will have a shortage, we need to do whatever it takes. So we will share the data only when we have the final report, because we are going to write it in exactly the same way that needs to be written. So in 10 years, those organizations that move in the wrong direction, if they do, they can refer back and say, and look at the mirror and see why they did wrong. And the ones that did fantastic, which I hope is the great majority, will be able to look and say, kudos, we did the right thing. So we will share, but at the right time, which will be, just so you know, this is going to go end of March, you guys will have it. So it's not that you are going to wait a lot.
Great. And in terms of the interpretation of the data, Doris, there are some requests, and Ermagine might have noticed some more, but Maureen's wondering if we might be able to see clinical specialties, for example, ICU,
Yes.
other requests to
Yes.
be separated by sector.
Absolutely. So we have all of that. So we will. Absolutely. Yes.
And then a question, are there any emerging themes of those that may be shifting into different care settings or pursuing further education as a vehicle to obtain alternative employment? So if that data is available, I'm not sure if that would be maybe in some of the.
We didn't ask about the issue of engaging in education to move to another sector, but it's something that we can continue to explore. And we can also include it in the Australian survey, because that's a very good question. Although one cannot assume that you are doing further education to move to another sector, right? So we need to word the question in a way that we are measuring what we are asking, not assuming. But excellent point, excellent point.
Yeah. And then a few comments when you were talking about employment status or leaving the profession. So Maureen is suggesting that there may be nurses who are working in more than one facility and then could no longer be doing that during the pandemic. So that might be some part of the interpretation.
So we do have actually we disqualified, but that's exactly the point she's making. I don't remember, Kim will know if it's 300 or 400 that put multiple employers. So we will be analyzing it to report on it exactly the way it is without making any interpretation, because we don't want to interpret why they work in multiple places. But as you know, there are many nurses that do. Thank you.
Great. And then, comments about retention just being such a critical issue to talk about, the concern about the workplace being toxic and experiencing burnout. And we certainly are talking about that at the Wellness Forum on those every 2 Wednesdays.
So I want to put that in context, Susan.
Sure.
Because you may remember that about 50 or a bit more of nurses said that their workplaces was very supportive. I just want to be mindful. I want to always start with the half full of the cup, and then how do we fix the other? Because if not, it becomes demoralizing for those workplaces that somehow succeeded. Like, I don't think any workplace in purpose is toxic, but obviously there are some, right? Sufficient numbers if you look at the scale. But I think it's important to recognize those that are doing the right thing. So we will.
Yeah, that's a great point. So I'll just say one more comment and then one question, and then I'll hand it over to you, Armagine. I see you've got your camera on. So Janet said, she's surprised that more nurses from long-term care are not planning on leaving based on how poorly they were supported. Most of the nurses planning on leaving the profession were from large hospitals. And so wondering if you had any thoughts on that.
We will, this is where also the narratives will be very helpful, right, to us, because nurses provided how many pages, Matt, of narratives, Matt, and like tons.
Yeah, it depended on the question, but we got
but overall, they provided tons of narratives in the comments, right? So
yeah, thousands.
So we will be analyzing that on the specific questions, especially when we ourselves will have questions about what the data means. And all, yeah, absolutely.
Great. And one last question from Rhonda. Do we know that those who did not take time off did not because they were coping or because they could not get the time off? How many take time off but were unable to?
Right. And I a bit commented on that. So I said heroic that 70 or 75% didn't take time off. It's a question, right? We will look in the narratives, probably a mix of all of the above. The largest reason, probably, Rhonda, is the guilty feeling. This is typical in nursing, as you and many of us know. You are not going to leave your colleagues, you're not going to leave your colleagues alone and abandon them and all the rest. And in fact, some of the ones that worked 50 and more hours, the syndrome was similar. And I cannot go into comments of some of the people in the profession that have had serious issues, but many of them were working huge numbers of hours for the same reason of wanting to help, and not realizing the burden on themselves, right? Until sometimes it was too late. So partially is that if they were working as casual, for example, right? Well, as casual, you don't have benefits, right? So you take time off, too bad. So likely it's a mix of all of the above, but that's where we can do cross-tabulation between the answer to that question, the employment status Kim will be doing, and also the answer to that question separate and the age, and the answer to that question and sector. All of the above will be very important.
Okay, Susan, if none more from you or no more from you, and you've absolutely captured almost everything that I had. One of the areas that has been mentioned, though, is in relation to the healthcare organizations. The slide where you said you were very pleased. And is there thought about how we might share this with healthcare organizations, maybe as a segue into some of the other comments that were made? A question, how do we make organizations accountable to tailor nursing support as a result of this to the strengths and I'm adding weaknesses of teams?
Yeah, and I think about learning about their best practices, right? So I think what will come after this, in addition to looking at the narratives from which we can learn a lot, it will be we call it the Aussie survey, but the survey that we are doing internationally, because we will see trends across the globe on some of these things. But also for the person asking, focus groups. It will be very important to put a call to all these people that responded and see if we can get 1 or 2 or 3 focus groups specific to certain themes, right? So this will be one that is very important. It reminds me work that we did with the late Heather Laschinger 10 years ago or so on the issue of work environments, etc. So absolutely, yes, we will be following up with some focus groups in the summer, likely when things are a bit more calm.
And another area you had mentioned, the issue of the stress and overlaid on the length of the pandemic, and someone did write the comment toxic and burnout in terms of the environment, and I just lay that out there as a comment. Although when you mentioned the use of the word nurse and the respect nurses were looking for, another comment about layoff of RNs during the pandemic sent a message that was not supportive.
Well, all of the above, right, Imagine? All of the above. I cannot underestimate the impact of the length of the pandemic. I think if everything had been perfect, i.e. perfect human resources, which we didn't have, i.e. perfect PPE, which we didn't have, i.e. all only working 45 hours because we had the right human resources. Even then would have been difficult, guys. I'm sure that if we go to South Korea and to Adelaide in Australia that did very well, and to, you know, other places, New Zealand, they will tell you it was tough. It was tough for everybody. The problem in Ontario is the layering of the difficulties. So not only the length, but actually not having the resources. The length and not having the resources and not being recognized. The length and not having the resources, not being recognized, and furthermore, having another group, which we respect, IEPSWs, being recognized more than you, when you were the one as a director of care, staying 17 hours in long-term care, but not being paid the 4 hours because you were not frontline. Like the layering of the issues is what becomes such a burden. Imagine and you, Susan, and others that we work together with long-term care during the height of the pandemic and to this day, we have seen them cry. They cry in front of us. They break into crying. That's not normal, guys. That is burden. That is emotional pain of not being seen and seen. Forget the heard, seen. Right?
Actually, Doris, that begs the other question that has been asked. Someone said, I'm surprised that more from long-term care have not indicated they're leaving. What are your thoughts on this when more are from what would be the protected sector of the hospitals?
Two things. Number one, from the protected sector, they have a lot of more opportunities, Imagine. You know, they can take their toolkit of knowledge and expertise that is prime pay, prime respect, prime kudos anywhere, whether to the US and watch it because Biden is not Trump, thank goodness, and he will attract every single nurse that he can with no shame. And we haven't even talked about that in this province. And they will go after their ends as they did during My thing, now I'm with Biden and I forgot the previous president. How shameful is that? Not Trump, but the handsome one,
Oh, Obama.
Obama. He is handsome. What can I say?
Yeah.
Handsome. In any case, you remember during Obama, guys, they came here and they took every single RN they could. Just watch it. Biden will too. And they have put top nurses in top positions. So they will pay well. They want all RNs with BSCN. So just watch it, because I'm in touch with that group there. And we better watch it if we don't do something here for our own Canadian nurses that is good across this country and in Ontario in particular. As you know, Canadian nurses are super well respected in other parts of the world. So they have more ease of going, Irma, to the colleague that asked. They have the toolkit here. You know, the luggage is here in their head, and they just take it and go.
Yeah.
Especially the younger population that doesn't have the roots set in terms of family here. So we better be careful. And this is not to say that in long-term care, my hunch, what we will see is retirements if they can afford it. Because your population of RNs in long-term care are for the most a more seasoned nurse. And my hunch is we will see retirements unless, again, we fix that sector, not in 4 years, but now.
Okay, I'll turn it back to you, Susan. There are a few
Doris,
more
yeah.
questions.
Well, maybe I'll ask the first one about deprivatizing long-term care. And then there's one, it's more of a policy question about mental health and psychotherapy. So Katie asks, is there any movement on deprivatizing long-term care homes so that there are accreditation standards that must be adhered to instead of being driven by profit? Other people are mentioning in the chat box about profit. Even after hospitals took over, we are still having significant problems with nursing homes. I'm a hospital RN, by the way, but this is something that really bothers me.
Yeah. So let me talk about what's going on, and let me talk about RNAO's position, and let me talk about even if hospitals. Let me start with the latter. Even if hospitals, you know that hospitals were given 300, 400 beds of long-term care. A huge number, I think 7 hospitals or 6. Those long-term care beds will be managed mainly by extended care. So the fact that we say hospitals doesn't mean that it's not for profit. Let me start there, okay? So that's a problem, because it's a disguise. It's privatization by disguise. Was given to hospitals, but in fact will not be managed by a team of the hospital, will be managed by extended care. So that's privatization, it's the same. If the world was perfect, and I don't think it is, and I would suggest to you, we would follow always only the evidence. And the evidence is clear on any health sector and on any country that I know it. Not for profit delivers better care cheaper, period, end of story. No questions asked. And then you get into specific long-term care, and the discussion becomes corporations versus mom and dad shops. And it's very different. And the same goes for home care, by the way. Corporations that are owned by shareholders versus non-corporations. If those are corporations, i.e., so many, right? Chartwell with Mike Harris, and I can send you the list of the 2 million he makes a year in each board, 2 million each year in each board, or several of the others. Their legal duty is to shareholders. That is their fiduciary responsibility, no questions asked. And so, you know, to the point that they will take money that they receive from government to do whatever they do. So the question then becomes, how do you tackle it? So in our view of RNAO, new beds should go, and always we have said it, as a priority to not-for-profit delivery. We are talking about delivery here, right? So already what happened with all these beds that went to the hospital is a disguise, because yes, it went to not-for-profit delivery, the hospital, but they will be managed by extended care, so it's not, right? And then where we are putting our foot completely down is on the issue of standards, because even if there is a government that wants to deprivatize or deprofitize, will take decades to do that, because otherwise, where do you put the seniors, right? So what will need to happen, that we could have done it and we didn't during the pandemic. Nursing homes that are not performing, I mean, many of you work in the hospital. When you guys were not performing and your budgets were bad and you had issues of human rights complaints and they put a supervisor on you. Well, here the supervisor should not be a hospital. They should pull their license or suspend their license. That's what they should do, and give it to another nursing home that actually does good work. That's number one. That's what they do in some other countries, but we don't. Instead, what we did is protect them, right? So some of the same chains got extra beds. You look at Orchard Villa, they got extra beds, right? Chartwell, I believe is, or whatever is the company. In any case, not only that, we protected against lawsuits, right? So the families of these persons that were abandoned, not abandoned by staff, abandoned by government and by the chains and by whoever else, because the majority of the death happened actually in chains, a huge percentage, much larger than in not-for-profit. They got protected. No one can sue them even, right? So we are saying basic care guarantee, whether you are in a for-profit or not-for-profit, 4 worked hours a day for every single resident in long-term care. Of that, 48 minutes of an RN, 60 minutes of an RPN, 132 minutes of a PSW. That's your 4 worked hours. And then we are saying on top of that, 1 NP for 120 residents. And if there is no NP in that region or community, then a CNS. And then we are saying 1 IPAC nurse for each home, and increasing according to how big the homes are. And no, they should not depend on a hospital, or they should not depend on anybody else. I need to tell you, and I will say it publicly because I said it to the commissioner, that when I got at 11 p.m. a call from the minister in charge, well, not in charge, in the riding of Orchard Villa, with 2 CEOs of hospitals to help them, my comment was, I want to talk with the nurses there. And Daniel Lau knows that it took us days to find the nurse that was looking after IPAC. And that nurse was from extended care, and she used to visit once every 2 weeks. So homes need their own resources, same as the hospitals have it, and same as any other sector has it. Nursing homes need their resources to deliver the work that residents in nursing homes, young and old, need, period. And that's for not-for-profit and for-profit. And then it comes the issue of how do you deprivatize the sector? Because we live in Canada, not in another country.
So Doris, before we leave the topic of long-term care, I'm going to go over to Erin's question, and then we'll talk again about mental health and psychotherapy. So Erin, well, it's a comment and a question. Erin's having a lot of meetings with MPPs about long-term care. And they discuss the need for more full-time RN positions, versus nurses having to work 2 to 3 multiple jobs to make a living. So they talk about positive impact that this would have for patients and continuity of care, as well as the culture and morale of the staff in the long-term care facilities. So that really aligns well with our nursing group basic care guarantee. Her question is, are we able to break down the results for long-term care RNs only in order to see the full impact of full-time versus part-time roles on stress levels, satisfaction?
We can. Yes, we can. We can, and that's a cross tabulation that Kim can do. But I think first we will look overall what we do for the sake of the survey, and then we will need to figure out with policy and myself on how do we respond to individual needs that some sectors may have, and both from a policy perspective and advocacy. But as the comment of the colleague before said, can we share more about the organizations that did well, right? In terms of employment. So we will do what we will do. First of all, these questions that you all are asking and writing in the chat will help us inform the detail that we provide in the report. We need to provide, of course, enough detail that is meaningful for you. And then at some point stop so we can put the report out, and then we still can continue. And then remember, there is a second, much more in-depth and long report. In fact, my colleague, you will laugh about this, Matt and Kim, my colleague from Spain, Maite, left me yesterday a tape in the WhatsApp. Hi, Doris, in Spanish. How this survey is a never-ending survey, and I'm translating this survey. Who is going to answer the survey? She said, because it's a lengthy survey. But I hope that we will develop the strategies and the chocolate bars that we will give to people to respond, so they can take the chocolate bar and respond, because it's a very serious survey. This one, Susan and colleagues, all of you, this was to check the pulse. This was to check, is it what we are hearing from nurses this way? And also to prepare for what might be a withdrawal from the workplace at the time that we need to do solutions to make sure that doesn't happen, and put a stop in the pedal, and also policy imperatives that need to happen to prevent an exodus.
Great, thanks, Doris. So I'm just shifting to wellness and mental health. Comment or question from Jessica, and I'd encourage Jessica and any others to join our Wednesday every 2 weeks, our open forum for nurses, how they're doing during the pandemic, and we can put the link in the chat box again. Jessica asks, because we are talking about these kinds of things at the forum, so Jessica's asking what wellness programs are available to nurses to help them cope. So we do talk about that on those Wednesdays, and also we put a link in the chat for all of the psychosocial resources that RNAO has compiled for you, and that's in our COVID-19 portal. So there's tons of great stuff there as well.
If I can add, Susan, one of the reasons why I think both nurses and non-nurses responded of RNAO doing very well for them is the immediacy of us responding, which is in addition to all the resources that Susan put in the chat, and in addition to the webinars and to the focus groups that Heather organized, that are Facebook sites that they can share, and all of that. There is the fact of how responsive RNAO is, and that goes for the entire staff, from the receptionist to the policy team, to you, Susan, Heather, Imagine, Matt, Kim, everybody, PG in my office, Ifra, myself, the board, the staff, on how attentive we are to not only to our members, to the people that write to us. How much, explain to them, Susan, because I think I think we need to take credit, and you need to also take credit alongside with Sabrina and many others that help on that, on the decision tree and how we responded from day one. Like, remember, first of all, daily blogs. Who else did daily blogs, guys? When I think back, I cannot even imagine, but I understand why I was sleeping in the sofa. Daniel with the Via Nurse daily and at night with Carrie, Robert, and the entire team. Share a bit, Susan, the decision making that was developed to answer to the questions of people like this.
Yeah, sure. Well, we were getting, probably hundreds of calls and emails, and, we value responding really quickly to your needs and making sure that it gets routed to the right person. You don't get trapped in, this emails getting lost. So a team of us worked together at RNAO to figure out, depending on the different type of call, who should that call be routed to, and so that we could get your answer in a timely manner. Especially some of these were really urgent, like getting PPE. We need PPE right now. We need nurses right now in the time that we had Via Nurse active.
So let me add to that, just to dive deep into exactly that piece. PPE, they did all the pieces that they needed to do with the links. It didn't work. I got a WhatsApp message that went directly from me to the minister's office. And those places got PPE right away. Like, we really had it a well-oiled machine to be like this, responding to try to decrease the stress. And you see the level of stress despite that. Just picture if that would not have been there. Yeah. And I know that Ona also was very attentive, guys.
Yeah.
Sorry.
In our team, actually, things have evolved so much now, almost a year later. So other members of our team just revised our algorithm, our decision-making tree, to figure out what kinds of questions we're getting now and who those should go to. So we're always trying to do our very, very best to respond to you in a timely way that's helpful, really addressing your problem that you're dealing with. Or celebrating the wins, and Doris highlights those wins and good news stories in her blog.
And on the cheering up, I mean, at the beginning it was needed, right? At the beginning, it was needed.
So we'll revisit. We've got a slide. Actually, maybe Doris, you can advance your slides to the.
Will do.
The candlelight vigil, just so that people can be ready for that. Yeah.
So let's remember that this Thursday, I mean, it's difficult to think it's a year, right? A year of this mess, quite frankly. That probably each one of us knows a person that we lost, either as a friend, as a family, as a neighbor. I certainly know several, and I'm sure others do too. Each one knows for sure, if not, people that contracted the virus. And we also know that there is kind of hope coming finally, right? I mean, last year I didn't even have time to plant anything. My little tomatoes are showing their face already here inside the house. The vaccines are coming. We hear there is a music of hope, right? Finally, I know it's 3-4 months ahead still, but there is a music of hope. So the idea of the candle is for both. Is for remembering the hardship and the difficulties of this last year. For remembering that everybody had a tough time, and yet some had an even tougher time, long-term care, people in the streets, people with opioids, that their crisis was even forgotten. But we have moved from 5 people a day to 6 people a day. In fact, it was 4 before the pandemic. Now it's 6 a day. And also to see the light ahead. But within that light ahead, which symbolizes also the candle, is the fact that this survey needs to be taken as a warning sign and not as an excuse to move with even worse decisions and policies that will put us more in the bricks of collapse. So that's the idea of the Thursday, 2 things that we will be asking, and you will see a press release because we invited all other professions for this. I need to give credit to my friend Tim Lenartowicz that tweeted to me, he sent me a text the day after the Queen's Park Day to say how fantastic Queen's Park had been. And Doris, can we do something with the candle? I don't know if he said the candle, but I think to commemorate the year. So Tim Lenartowicz, if you are there, thank you. Right away, I said, let's look into this. And then Marianne took it on with her counterparts in other associations and etc. And it's moving beautifully now. And so we will ask you 2 things. One is that you put in the screen a candle, and RNAO is offering 2 candles in our screen. You will see it. So you can choose those. They're very beautiful. A selection of Marianne and PG. They're beautiful. And you can put another one if you don't like those. It's your candle. And then that will be in the screen the whole day. And then at 7 p.m., simply to step outside the door with a candle, just to reflect and to smell the hope, both.
Great, thanks, Doris. I just want to return to Sheena's question. Sheena's asking, given the new data, I'm wondering how RNAO can support RN's mental health, specifically moving on the RNAO resolutions regarding RN psychotherapy and OHIP coverage and private insurance coverage, for example, Industrial Alliance, Sun Life, and Manulife, to allow for us to care for our RN community by increasing access to mental health care and not interrupting psychotherapy care when our RN colleagues choose RN psychotherapists.
Yeah,
Or
for sure.
Yeah.
For sure. So number one, remember, we were waiting for that in psychotherapy to move. So first, let's say thank you that RNAO moved that, because as you know, that was not in the books. So kudos to that, and to our mental health nurses interest group that really pushed with us together to move that. So that's number one. Number two, we are working very, very heavily with the insurance companies related to nurse practitioners. Beth Sweeney, which I hope is here today, she's our lead person for that. And we will be adding to that Beth take note, or Matt take note, the issue of RNs for psychotherapy. Good point, thank you. Now, we should have it as part of all the services, right? Not just through private insurance, but that's a different topic.
Yeah, great. Okay, another question from Rhonda. Do we know how many vacations were canceled early on in the pandemic? And then Irma-Jean, I think there are a couple of questions that I may have missed, so why don't you ask them after?
Okay, will do.
You know, we didn't ask about that, but that's a good question, Matt, to put for the Australian survey. I am sure a lot, because I remember first wave, almost all the vacations in long-term care in most of the homes were canceled. Yeah, yeah. And I know for a fact that in ICUs, in many instances, they were not canceled, but they were asked, could you? And many did, right? But in long-term care, they were canceled automatically. They were not even asked.
I know, Doris, that did come up when we surveyed the NPs, and also I think it's in some of the comments for this survey. Okay, let me ask a few more questions. The one Susan has pinpointed, it's how well is the role of RNAO ambassador going?
To the schools, or to where? To the schools?
I'm not sure with the questioner. I'm not sure they meant the schools. I'm wondering if they meant the workplace ambassassembassador.
No, that's the workplace liaison. So I'm not sure. Let me answer both, though. Let me answer. Says workplace.
Saying workplace.
It's going very well, Maria. I see it's Maria. The reality is, though, that workplaces haven't had a huge time to deal with specifically that role, right? Even the workplace liaison haven't had a time to deal with that. So it's going as good as the can be within a pandemic. But as a proxy, and it's different, but it's a proxy. Let me tell you that we had 46 visits with MPPs in the middle of this pandemic, right, by members. That tells you that members are willing to put the time, you know? And that was just during the Queen's Park on the Road time. Let me tell you that all the politicians came to Queen's Park Day, including the Premier, all the opposition leaders, the minister, the health critics, all of them. And we had what, 160 members, I'm assuming. So all in all, and maybe that's why people feel happier, if that's the word that we can call it, or less stress when there are RNAO members, because they have an outlet, right? Like they have something positive that energizes them and takes them away from this, cannot get away from it, which is a comment, by the way, that one of our colleagues made in the heart-to-heart conversations on Wednesdays that we have about the continuing the conversation. One of them said, you simply can't get away of it, the pandemic, right? So maybe these other initiatives too, versus the workplace liaison, remember, is in their workplace. So not only they cannot get away of it, puts them more in it. But good point, we will check with them.
Okay, so I think there's 3 other questions I have here, Susan. The other is in relation to, oh, I've just lost it here, OHTs. And you did talk about OHTs, Doris, but the comments seem to be, how do we like fast forward transformation with the OHTs so it happens right now?
So first, let me give a comment and kudos to Susan and Kristen Campbell and Olivia, and then pass it on to them to brag. Because the 4 OHTs, PG or Anne-Marie, can you put the last slide with the candlelight? By mistake, I think I closed it, so people can take note of that. In the midst of this pandemic, the BPSO OHT, so for those of you that don't know what it means, is if this is a BPSO, sorry, if this is an OHT, this is the BPSO OHT. So we are inserted as part of the OHT, and our focus is on evidence-based practice and on staff engagement. Evidence-based practice with 4 mandatory BPGs, person and family centered care and transitions in care being the 2 mandatory, and then 2 clinical that they choose according to areas of their priority. And then staff engagement through not only knowledge to action, but also through social movement, which during the pandemic was like manna from heaven, I think, for many of them. So heavily involved throughout the pandemic, and they focus on the person-centered care. And then in the middle of COVID pandemic, we announced 3 new BPSO OHTs. So that tells you. And the government also announced additional OHTs. So is it enough? No, it's not enough. And we just got funding, so we will likely be engaging even more. So if any of your OHTs is interested, put them in touch with Susan. But Susan, share a bit about the comments that they made about feeling energized, etc., and also the venting that they took time to do with us. Please go ahead, Susan.
Well, I guess even though the pandemic was going on, because all of the BPS OHTs were implementing the person and family centered care guideline, they it really rooted their work. It was kind of like a pillar for their work that they could come back to and recognize that what they were focusing their energies on during the pandemic response had a great deal to do with person and family centered care. So it was really reinforcing for them, and really you know, they were sharing their strategies amongst one another within the organizations and really accelerating that change. And when we met in September, we had a meeting of all of our first BPS OHTs that are participating in the program, and that's 4. And we had a meet and greet event, and they were highlighting their successes, and they just had so much to profile in terms of the momentum that they were able to maintain, keeping that person and family centeredness, like virtual care being an example, or really meeting the immediate, urgent, practical needs, accessing food, housing, cell phone data, those kinds of things. So that helped the guideline, the structure of the program, and banding together really helped to solidify the work and accelerated them working as an integrated system of care. So that just continues to build momentum. And now we have at least 3, maybe more OHTs joining the second cohort. So do you think that's kind of what you wanted me to highlight, Doris?
Totally. And just to give kudos to the work that Susan and her team are doing on this, because it's fantastic. It's fantastic. I just go and enjoy and visit. And from time to time give ideas, but it's spectacular. And maybe you want to share alongside with that of the next steps for the Leading Change Toolkit to end up in something really energizing, Susan. For you and Kath, very briefly, for you,
Yeah.
recognize the work of Catherine and of Shelley and of Janet, all of us, and the international panel, all of us. It's just
sure. Yeah, I'd be happy to do that. There is one other question that I do want to make sure that we answer, but I will talk a little bit about the Leading Change Toolkit. So we are so excited about this new toolkit. It's going to replace an implementation toolkit that some of you or many of you might be aware of. The toolkit is really focused on how do you go about implementing best practices in your organization. And this next edition, we're using that same knowledge to action framework that we've used in the past. And that is more of a, it's based on change theory, and it's more of a phase or step-by-step approach, organized approach at implementing change. But coupled with that, we're really, really excited about the social movement action framework. And this is formalizing our knowledge and experience of social movements and creating change through our best practice spotlight organizations that we've witnessed around the world and here in Ontario, as well as the work that we've done in our policy department with mobilizing people for change. So we formalized that this last year and a half or so with some serious work with a concept analysis, and we have a research team who's conducted that together with an international expert panel. And so we've done this formal academic work, and that is being translated into very practical resources, tools, and examples that you can use to accelerate and mobilize change together with teams in your organizations. So we're going to be releasing that in June this year, and it's a living toolkit. So if you have examples and videos and things that you want to share with us that we can put on the toolkit in the future, we can continue to do that because it is online. And it is going to be a living toolkit, but that's going to be available for you and your teams to mobilize change and lead to transformative change. So and it could be applicable to any evidence-based kind of topic. And we're really excited to share that with you. We're actually currently recruiting. So now there's a plug, Doris. I'm going to put in just a moment the link, or maybe Olivia, you can put the link to sign up for recruiting for people who are willing to take some time to review some of the toolkit before it goes live, and give us some feedback on, is this practical? Is this useful? Can you find your way? Do you like the way it looks? Can you understand what we're talking about here? So you're user testers. So if you want to be user testers, Olivia, if you can send that, or I will in a minute, the link to sign up, because we really need to make sure that it's meeting your needs, because it's for people like you. Thanks, Olivia.
So talking about plugs, it's never too early to register for the AGM. June 24 to 26, and I will tell you why. Because Susan has the Leading Change Toolkit that will revolutionize the world to
Oh,
kind of fancy up and share. And Matt will have the new website fancy up and share. But I have in the closet some news that you will savor. That's all I'm going to say. So come to the AGM because you will leave with a lot of good information and good news. Yes, and who knows, we may even have the results of something that will be less exciting, which the results of the bigger survey, but I don't know if we will be ready for that, but probably we will be ready with some preamble on that too. But it will be a packed AGM with lots and lots of information. Just so you know, we haven't had the resolutions committee meeting yet, so I don't know if all the resolutions that were that came to RNAO are in a shape that will move forward, but 20, I don't know how we will deal with 20. So I hope that some of them actually can, you know, they missed whatever. They missed a lot of things because we can't have 20. Yes. Any other questions, Susan or Irma-Jean or Matt? That in
yes,
the chat?
Doris, it's we've just got 10 minutes left, so let's make sure that we answer this question. And then also, Doris, if you could go back one slide so people have the information about the next forum on next Wednesday. So just one slide back. But this last question, I think, is this pandemic is definitely demanding change. How about supporting families to take care of their elderly at home instead of a nursing home? Home care is not enough help. Families could do better if they received the money. So can you respond to that, Doris?
So absolutely, I will. RNAO has been on record for a long time, including in some of the webinars that we did, that ideally the best place for older persons to stay is at home. I would not say, though, give the money to the families, because sometimes it's the person that wants to manage their own affairs. They don't need the family, they just need the support to call the help they need. But it needs to be done in a way that is not, you know, your coupons, that everybody gets the same coupons, you know, because some people have much, much higher needs. They need more care. They need more hours, they need more support. It needs to be about bringing everybody to the level that they can be to receive care at home. There are models like that. Europe is like that in many places. Denmark is like that. I can tell you for sure that in Israel is like that. And in fact, when you look at OECD reports, it's one of the areas of success, both primary care and long-term care. Where lots of people can stay at home, my mother-in-law included, right? With the right supports that she can manage, and she loves it because she will never want to go to a nursing home. So it is something we are working. Samir Simha also is working on the issue of keeping seniors at home. But that's not to say that homes need to be good places, because sometimes you cannot stay at home, or sometimes you cannot keep your family member at home for a whole variety of reasons. So we need to do both, facilitate for people to receive government funded resources, baseline that will enable them to stay at home, and have a dignified and safe life, safe also. And second, that we fix long-term care because we always will need them. You will not do away, but you also can structure them in a different way. So not all of them should be these mega buildings, right? There are different models again in Denmark and in fact in BC. In BC, that is the village, right, for seniors with smaller places that you go according to who you were before, you know, like put me with people that do plans, I say, or people that cook, or people that want to have political debates. Put me there. Put Ricardo there too. But another person, maybe put them in a place that is to construct things. And right, and that's what those villages do, because they work on maintaining not only dignity, but maintaining dignity according to the very well thought out and well known theories of maintaining cognitive capacity, right? And things that you did all your life, you can maintain if you're put in the right environment, versus what we do now. Everybody's in this home, they wake them up at the same time, and this is when the shower is, and this is when the bath is, and it's because the way we have structured them is not right. If you don't have staffing, how much accommodation can you do? You still can do some. You still can do some, I would say. But if staffing was better, you know, it certainly will be more dignified and safer. So we hear you.
Thanks for that, Doris. So we're getting time to, it's almost time to close. And I just wondered, Matt, I saw your camera come back on. Was there anything more that you wanted to say before Doris kind of closes the event?
I only put it back on to say thank you for attending, everybody, and thanks to all the staff who helped support today's event.
Absolutely. And I don't know if Morgan was able to join us, because then I would like her to close rather than me. Or Angela, if Morgan is not there, Angela, just to thank people. From my end, thank you absolutely for the tremendous work, to the policy team, to the comms team, and to everybody today, a big thank you. Morgan or Angela, are you there? I thought I had seen.
Hi, Doris. I don't think that Angela and Morgan are on anymore. I think they may have just.
Okay, no problem at all. Thank you very, very much, everybody. And thank you for the work you do every day. There is no words that ever any of us, whether it's RNAO, whether it's your employer or government, can say to thank you enough for those of you, especially in the front lines, and also for the middle managers, nurse executives, and everybody in between. Thank you, thank you, thank you, thank you for the work you do.
Okay.